For the next three videos, we're going to start talking about the biological basis of behavioral disorders. So getting into more psychopathology, so more of what we're interested in clinical psychology and in psychiatry. So with this, one of the things that I think is really important for me to get across is how we know what we know in this area. And with that, most of the findings that I'm going to share with you, most of these hypotheses are correlational hypotheses. So what does that mean? That means that these are two things that are related. You have what we call a concomitant variation, which is that as one goes up, the other goes up, or as one goes down, the other goes down. So there is a relation, but we know very little about causation. So for causation, you need three main pieces of evidence. You need temporal priority, meaning that the cause comes before the effect. You need that concomitant variation, meaning there must be a strong correlation between the two pieces, the cause and the effect. And lastly, you must eliminate all the other plausible alternatives. So you must control for all the other possible causes and show that it's not them. As you'll see, very little in this area reaches this very strict level of proof. So keep that in mind that we're talking about correlations, and more research needs to be done because we don't fully know how these psychological disorders manifest or even how their treatments work. And I really hope to show you that there's a lot that we don't know. So first, just touching a little bit on psychopathology in general. About a third of the population in the U.S. will meet criteria for a psychiatric disorder at some point during their lives. So while this isn't a majority of people, this is still a very large proportion of the population that at some point will be experiencing clinically significant symptoms of a mental disorder. Further, 19% of people have met criteria for a psychiatric diagnosis in the last 6 months. So again, a lot of people are struggling with these issues. The most common diagnoses or disorders, first are anxiety disorders. They're the most common, followed closely by substance disorders, and then affective disorders. Affective disorders including depression. So in this first video, we're going to focus actually on schizophrenia. Schizophrenia is not nearly as prevalent as many of the other psychiatric disorders we're going to talk about, but it's a very severe disorder that seems to be more biologically based than some of the other disorders, so it seems like it's a really good one to start on. So with schizophrenia, there are several symptoms that are common. So one is dissociative thinking, which is a condition that you see that is characterized by disturbances of thought and difficulty relating events properly. So it's problems putting things together as far as thought content. You may have thoughts that don't really fit and don't make sense to other people. You can also see cognitive deficits, and also auditory hallucinations are very common. Actually, people don't realize auditory hallucinations are much more common than visual hallucinations for schizophrenia. Also, these hallucinations are almost always negative, so they're not telling someone something positive, they're almost always saying something negative. Onset is usually in the late teen years to the mid-20s, but it can happen as early as childhood. So with that, I have a video that I think is a really good video that shows the effects of schizophrenia and some of these symptoms. So I want to show that next before we get into the symptoms. This is a childhood case. Again, these are rare, but I liked this video because I thought it really highlighted a lot of the symptoms, so then it will help make it a little clearer for you to see.
What do you want to be when you grow up?
A veterinarian.
That's right.
No, I'm going to be a number checker.
What's a number checker? Do you know?
Yeah, it's where you get to draw numbers' blood and make them feel better.
Draw numbers blood and make them feel better. Are you seeing a lot of numbers right now?
Yeah.
Where are they and what are they doing?
2 tens. The real 10 and the imaginary 10.
Sometimes I wonder, is she seeing stuff and that it really is there, it's just we're not seeing it? Is that what's happening, Jenny?
Yeah.
I don't know.
My 2 hopes for Jenny are very simple. I want her to be alive, and I want her to be able to find moments of happiness in the day. Even if every day isn't always happy, that she can find some happiness. That's it. That's all I want from her.
So if Daddy ever comes...
No, Daddy's going to take a break right now, so I'm staff, okay? What do you know of schizophrenia?
And it makes you have imaginary friends.
It makes you have imaginary friends. Are you schizophrenic? Do you know?
I think I am schizophrenic.
As a baby,
You'll notice at times that she's wiping away drool. That's actually a side effect of the medication.
she never slept, and that's as I always say, it's not hyperbole. She literally would not sleep. She would do 20, 30-minute power naps 24 hours a day. So as a newborn, she was getting 2-3 hours of sleep a day. Otherwise, she'd just scream. Until we one day figured out that when we stepped outside, she stopped screaming. We went back in, she started screaming again. By 3 months, we were taking her out all day, every day. And we did this for 2 years straight. One place wasn't enough. It's like her mind was a sponge. We'd go somewhere, she'd absorb it, she'd grow bored with it, and then we'd have to move on to the next place. So we might go to the zoo, a play area, and Barnes & Noble play area all in the same day. At 2, she started to talk about what we thought were imaginary friends.
Why?
The first one to appear was 400 the cat, and she would just play with 400. We didn't think too much of it. Oh, I know what she needs. You need a Thorazine, Jenny. The medication, the Thorazine, for every delusion that the Thorazine kills, another one comes to take its place. And Jenny's unwilling to let go of the good ones because they're her friends. She had always been very, very social because, of course, we were out all the time. But then, right around her 3rd birthday, she started to become antisocial. She would scream at people if they called her January. She would tell her friends that she didn't want to play with them anymore. At one point, she had probably as many as 20 or 30 friends, and they just, slowly all dropped away. And the number of imaginary friends kept growing and growing and growing. And then, at 5, the violence began. She began hitting, kicking, biting, throwing shoes. When I would say that she would hit, these weren't like tantrums. The impact of her blows was like she was fighting for her life. And there was no warning. One moment she's like, I love you, Daddy. And then all of a sudden, she is literally trying to scratch my eyes out. She would be like that for 10 or 15 minutes, and then she'd come dead after it. Slowly became obvious, but not till she went into UCLA, that she was disassociating from those violent moments.
This is Miss 60.
And really didn't remember them. She knew that she'd done something wrong, but she didn't know what.
She was 5 years old, and he was born. And she was running around the hospital going nuts before any medication. I grabbed her. I just grabbed her and put her on my lap. And she turned to somebody who was not there and said, "Ooh, she's not pregnant anymore," in that kind of a voice. And it kind of freaked me out. I'd never heard her talk like that. I'd never heard her talk specifically to like somebody else. We knew she had all the imaginary friends, but it didn't quite, it started to sort of add up, basically. But we did take her to a psychologist because It got to the point where we couldn't live with her.
All right, sweetie, how you doing? How are you doing? You ready to go swimming?
That one, Bodie. Do you think you see your friends more now or less since you went to hospital?
More.
More?
Yeah, more. Because Thorzine's not helping very much.
Do you want them to go away?
400 I do, and Wednesday I do. Because they're bad.
How are they bad?
They tell me to do bad things,
What kind of bad things?
like hitting and screaming, kicking.
What does it feel like when Wednesday tells you to hit or kick?
Wednesday bites me until I do it.
Okay, what does 400 do?
She scratches
She scratches.
because she doesn't know how to hit.
So originally we had a 2-bedroom apartment in this complex. Keeping Jenny from hurting Bodhi was a 24-hour-a-day job. So we traded in our 2-bedroom for 2 1-bedroom apartments. Jenny's apartment is in this building, and then right across the parking lot, about 100 feet away on the 3rd floor, is Bodhi's apartment. I mean, financially it's been harder because the 2 put together are still $500 more than what I was paying for the 2-bedroom. When Susan and I were living in the same apartment, it felt more like we were in this together. You know, since we've been in separate apartments, I feel like we are not as close anymore, and that leads us to attacking each other more, blaming each other more. It's because we have no one else to blame. Both of us are under such immense stress at all times. I wish she could have had more of a childhood than she has had, but her illness took that from her. You have to think about it like you have this sweet, blonde, normal-looking 6-year-old girl, but there are all these characters that are out to get her. And as long as she is occupied, they stay at bay. This is never going to be over. I mean, this is a lifetime illness for her.
So hopefully that helps give you a better idea about what schizophrenia is and what it looks like. What you'll notice is that there are both positive and negative symptoms. So positive symptoms are abnormal behaviors that are gained that people without schizophrenia don't have. So things like hallucinations, delusions, or excited motor behavior would all be positive symptoms. Negative symptoms are slow thought and speech, emotional and social withdrawal, which you remember they talked about some, and blunted affect or emotional expression. And as the book mentions, individuals with schizophrenia with this blunted affect show very little emotion. But that doesn't mean that they don't feel emotion. In fact, they report feeling very strong emotions. Thus, it can often be difficult for a clinician evaluating an individual with schizophrenia to determine how distressed they actually are. I remember having to do a suicide assessment on an individual with schizophrenia, and it was very difficult to know, to judge just how distressed the person was, because again, you're not getting those facial cues that are so important. So schizophrenia does appear to be at least partially heritable, which means at least partially genetic. So there's a 50% concordance rate with monozygotic twins. So meaning if one twin has schizophrenia, there's a 50% chance that the other twin will as well. And that is compared with a 17% rate for dizygotic. So the fact that there's a higher rate for monozygotic than dizygotic suggests that there is, in fact, a genetic component. So we know that there's a strong genetic component, but also the environment also seems to play a role. Some environmental factors that appear to be important are developmental difficulties such as low birth weight or impaired motor function. Also, if one's mother has had the flu during pregnancy, it can increase the risk of developing schizophrenia. And paternal age, so age of the father, may also be a factor, as older fathers are more likely to have children with schizophrenia. We haven't been able to identify a gene for schizophrenia, but rather it's believed that there are multiple genes that are involved in creating this vulnerability. And here again you can just see the rate for monozygotic twins and how it's significantly higher than for dizygotic or siblings. So you can see that there is a very strong genetic component. Also, if you look between these, you can see the increase in risk with each degree of closeness to an individual's schizophrenia. So we've talked a little bit about the larger ventricles before. The individuals with schizophrenia typically do have enlarged ventricles, especially in men. The larger ventricles appear to be the result of neighboring brain areas being smaller. For instance, the hippocampus and amygdala are both smaller in individuals with schizophrenia than in individuals who don't have schizophrenia. There are also abnormalities in the parahippocampal regions and other areas within the limbic system. You also see the pyramidal cells within the hippocampus showing a characteristic disorganization in individuals with schizophrenia. So that's what you can see here, where they're less organized than those normal controls. So these factors are thought to occur early in development and may help account for some of the cognitive deficits that are seen in the disorder. Other brain differences we see in individuals with schizophrenia are a thicker corpus callosum. Due to the consistent findings that individuals with schizophrenia have less activation in their frontal lobes, there's also a hypofrontality hypothesis that's been put forward. And this is that schizophrenia may be caused by an underactivation of the frontal lobes. Interestingly, in identical twins, only the one with schizophrenia shows hypofrontality. So it seems to be a symptom of the disorder and not a direct genetic cause. If it's directly genetic, of course, you'd expect to see it in both of the identical twins. Also, during challenging cognitive tasks, individuals with schizophrenia don't see an increase in activation above resting levels, which may be part of the reason why there are cognitive impairments with the disorder. Further, drugs that seem to help schizophrenia also seem to increase activation in the frontal lobe. So, as you know by now, a lot of what we know about the brain is correlational in nature. We see that two things co-occur, and we assume that one is causing the other. And since we're in psychology, we also know that correlation does not equal causation. You know, anyone in the sciences, hopefully everyone, but ideally, especially those in the sciences, know that correlation and causation are not the same thing. So in this vein, one of the methods that's been used to look for a cause of schizophrenia is looking at medications that cause similar symptoms. So we know that drugs like LSD and other hallucinogens cause hallucinations, but they differ a fair amount from those seen in schizophrenia, which are more disorganized thinking, auditory hallucinations, and paranoia. So it's not typically what you would see with an LSD. However, these are the symptoms you see when someone has taken very high doses of amphetamines, and thus are suffering from a amphetamine psychosis. So the fact that an amphetamine psychosis and schizophrenia appear similar has led many to think that they may have a common cause. So how do amphetamines work? Well, as you may remember, amphetamines lead to a release of catecholamines, especially dopamine. Thus, the dopamine hypothesis of schizophrenia was born. So, thorazine, also known as chlorpromazine, was discovered in 1954, and it was one of the first psychiatric medications. It was actually designed originally as a treatment for malaria, but it was quickly discovered that it did wonders for people with mental illness. It literally revolutionized psychiatry. However, there was a cost. It also had significant side effects, such as tardive dyskinesia. The psychiatric effects of thorazine and many of the antipsychotic drugs, that the older ones, seem to work by blocking the dopamine D2 receptors. That seemed to be the real important active mechanism of why those drugs worked. So the typical neuroleptic drugs are all those antagonists of the dopamine D2 receptor. So these are the older antipsychotics. Typical are older, atypical are newer. And the typical neuroleptics, these older antipsychotics, again, are based upon the dopamine hypothesis. So the thought that schizophrenia results from an excess in synaptic dopamine or an increase in postsynaptic sensitivity to it. So either there's more dopamine or we're just more sensitive to it, is the thought here. Now, there are some problems with the dopamine hypothesis, some pretty significant problems. One is that individuals with schizophrenia have normal dopamine metabolite levels. So this suggests that they do not actually have excess dopamine. They probably have normal dopamine levels. Another problem is that the drugs that block D2 receptors, they're able to block D2 receptors much faster than symptoms are reduced. So it's not a cause and effect. Those receptors are blocked, and then sometime later you start to see some symptom improvement, kind of like what you see with SSRIs. So again, it suggests that that may not actually be, it may be a mediating factor, but it may not be the causal factor. And lastly, some patients don't get better. So that also argues against the hypothesis. So now there's a new class of drugs, some atypical neuroleptics, and these work by blocking serotonin receptors as well as D2 receptors. They don't block the D2 receptors as much, so you have less tardive dyskinesia, but they seem to be as effective as the old ones. There's a 2010 study by Crossley that was a meta-analysis examining typical and atypical antipsychotics, and they found no difference in efficacy. So the benefit of the new drugs, the atypical neuroleptics, is that they don't cause a significant of side effects. So they don't have as much tardive dyskinesia because you have less activity on the D2 receptors. The downside is they do have some significant side effects. For instance, many of the new drugs cause significant weight gain, and that may make it less desirable for an individual to be on them. So some have argued that the dopamine hypothesis is a bust, though I actually still somewhat buy into it. But regardless, it's at least not a clear winner. So thus we have a need for a new hypothesis. So enter the glutamate hypothesis. Much like the other hypotheses, it is purely correlational. Originally, it was originally designed to cause a dissociative amnestic state in which an individual is partially responsive but insensitive to pain. PCP was found to cause symptoms that strongly resembled the positive and negative symptoms of schizophrenia. Stop me if you've heard this before. So, further, chronic use of PCP can actually precipitate the development of schizophrenia. So thus, It is thought that whatever causes the effects of PCP may also cause the same problems in schizophrenia. So, what does PCP do? PCP is a non-competitive NMDA receptor antagonist, which blocks the effects of glutamate, the main excitatory neurotransmitter in the brain. For reasons you don't need to know, this hypothesis can also explain why atypical antipsychotics are effective, as serotonin levels and glutamate levels are related. Thus, it's thought that there's an excess of glutamate in individuals with schizophrenia. So, the glutamate hypothesis is the new thing. The book is gung-ho about it. So why do I still hang my head on the old dopamine hypothesis? Well, because blocking D2 receptors works. We know it has an effect. And both typical and atypical antipsychotics block D2 receptors. Further, we don't yet have strong evidence that reducing glutamate effectively treats schizophrenia. In fact, a study in 2009 found that a glutamate antagonist failed to outperform an atypical antipsychotic and a placebo. So thus, until there is strong evidence that reducing glutamate actually treats schizophrenia, I'm more inclined personally to stick with the old hypothesis. So as I mentioned earlier, while genetics explain a great deal of who will develop schizophrenia, they don't tell anywhere near the full story. In fact, some environmental causes have also been found. For instance, living in a city increases one's risk of developing schizophrenia. The authors postulate that this is due to stress levels, though others have questioned whether it could be due to toxin exposure. There are also several birth problems that have been associated, such as the mother being exposed to the flu during the first trimester of pregnancy, the mother and baby having incompatible blood types, and birth complications that cause a reduction in oxygen. Again, though, all these are just correlations, and often very modest ones at that. So they are at least something. We're at least finding things that are related to developing schizophrenia. But I hope what you can see is that we're far away from fully understanding why individuals have schizophrenia, and even understanding why the treatments that we have work.